introduction and with a large list of laurels to him. We have Dr. Amit Gupta, who will be talking on chest X-ray fundamentals. So someone who has all the knowledge about AI talking about the most fundamental, that shows how important that particular modality is. So Dr. Amit Gupta, over to you. And please let me know whenever if there is any issues, I'll be around.
Yeah, thank you, Dr. Khushbu, and I'll first try. Thank you first of all that amazing introduction. And again, as you mentioned, the basic things are always most important to us as well, whether you function in India or on the other side of the planet. So I'll start by sharing my screen. Please let me know if you can see my screen.
Yeah.
Can
So
you
yeah,
can you?
go. Absolutely. Yes.
Okay, and can you hear me okay as well?
Absolutely. Absolutely. So
All
we're
right. So again, chest radiography or chest X-ray, and again, I'm always happy to talk about it. It's a vast topic, so it's difficult to cover the entirety of it in 50 minutes or so that I've been allotted. But I'll try to. Uh, Let me switch on my camera as well. If in, so again, so chest radiography is a vast topic, so we'll try to cover the basics of it. So before we start, again, we feel that it is very basic. So it's very simplistic, three test questions that you don't have to answer, you don't have to shout out the answer, but you can easily think about it, and maybe hopefully you'll find the answer in the lecture that follows that. So this is first question, three radiographs on the same patient on one day. You can assume this one is in the morning, middle one is in the afternoon, and the bottom one is in the evening or in the night. So the question is, what is the pathology on the middle one? And how will you report this radiograph? It's the same patient on the same day, three radiographs. All right, so you can see this patient has a cardiomegaly, cardiac pacemaker, Mediports, and other things going on. But the question is on the middle picture. Okay. Number two, same patient, repeated radiograph. Uh, I see chats coming in, but we'll come to that answer in a bit, and I'll touch on that chat as well. The answer says migratory consolidation. Chronic eosinophilic pneumonia is something that was put in there as well, I guess, CEP. Uh, let's talk about the second one. So, same patient, radiograph repeated 5 minutes apart. So, what is the reason for such a drastic difference in these two pictures? And what the tech did right here or right here or right here or wrong here? That is the question. We'll come to that as we are discussing going through the presentation as well. Yeah, overexposure. Yeah, okay. We'll talk more about it. So, what's the likely diagnosis in the third one? It's it's uh, it's PA and lateral radiographs. That's all I can give you. The history is withheld, but history generally should be present during the radiograph, and the answers are coming. This tells me like how interested people are learning chest radiography. It's so amazing. So we'll continue at a fast pace now. And again, there are pneumonia and collapse, all kind of infarct, everything is pouring in. But I think more of it is more didactic, and we'll try to talk about those cases as they come in this journey. Okay, so we'll know the basics, an approach to radiograph, normal anatomy. I will spend most of the time on the approach of chest radiograph rather than what is white, what is black. Everyone knows white is edema, hemorrhage, edema, infection, and so forth. So if the time permits, we'll talk about my favorite topic, AI and dual energy radiography. But I think I'll concentrate mainly on the first three items here. So let's go with very basic so that there's no cramming happening there and everything is answered with a sense of like understanding. Uh, the radiography or radiology was born in 1895, right? So with the discovery of X-rays, the man himself, a German physicist, found something that he didn't know what it is. Since you in mathematics or physics, unknown is called X, right? So hence the name X-rays. So the name still persists today, despite the fact that we know a lot about the just X-rays or X-rays in general as well. So the first Nobel Prize in physics went to the the X-ray inventing person. First radiograph, whenever you find something new, you test it on your wife, and that's what exactly he did. And this is the first radiograph. You can see it on Wikipedia or anywhere else on the internet. She saw the radiograph and said, I have seen my death. And exactly that was the real fascination. And before that time point, nobody has seen the skeleton when a person is alive. And hence that comment was made. But again, the radiography brought a revolution subsequently in the next 2, 3 decades, and till today. The World War first started in 1914 to 1919. There were a lot of fractures, bony injuries, and so forth going on, not to say the other applications of plain radiography. But if you are first day looking at a chest radiograph, you will feel something is off in the picture on the left, right? So what is off here is, since I know like light is electromagnetic radiation, if you spray somebody with the X-rays and bones stop the X-rays more, we all know that, and the lungs stop it less. So why the bones are white? Why the shadow is white, right? I imagine the picture should look like this on the right. This is the perfect picture that aligns with my understanding of the electromagnetic radiation. But still, I see this picture on the left on my monitors, my films, or wherever you practice. So both are correct pictures. One is inverse of the others. But again, I can tell you that the difference is not in terms of something different has been acquired on the right, but how it is displayed on your monitor. And if you really dive back into the older era of film processing, where the films were washed, developed, fixed, and washed, right? So the areas which are white on the film are actually the areas where the X-rays could not penetrate the patient and reach the film. So it got washed out. So when you put it on the viewing box, the light passed through that. Hence the inverse image of the density on the screen, right? So this is the traditional way. Now we have the digital processing, right? So this is analog and this is digital. On the digital front, you can see that our detector sees this kind of a picture. But to maintain the similar convention that we have been learning over now more than 100 years, we invert the picture that is seen by our detectors as a garden variety radiograph image. But bottom line, for cramming, anything dense on the radiograph will look white. Anything rare or not so dense on the radiograph will appear dark. So that is kind of like why bones are white on chest X-ray, right? Second question, we are not dealing with only black and white, but the shades of grays, right? So we have a bone white, we have grayish soft tissues, we have whitest white, we have this markers which are metal, which are super white. So there should be some sense behind how the color coding is going on, right? If you go to a shop to buy a favorite color, this is might be a shade card. But for the radiologist, like this is boring, but it's still very interesting. It is all the shades of gray. So if you really want to decode what X-ray or anything that does with X-ray, whether it's a CT scan, dual energy CT scan, multi-energy CT scan, anything that use plain X-rays or X-rays in general will have a shade of gray. And if you can decode this shade card, you will never cram why this metallic thing is white or bone is white or something is rare. It's basically the science behind it. And the person himself is Albert Einstein. He's known for E is equal to mc square. But interestingly, the Nobel Prize was given to his discovery of photoelectric effect. And that is the most important discovery for radiologists as well. So if you really want to know something about X-ray physics, this is the only slide, and that is more than enough uh, to go ahead in your careers as well, right? So if you look at this graph here, which looks scary in the beginning, but it's very simple plot of X-ray energy and the stopping power going on the Y and the X-axis, right? So if you obtain an X-ray at low kVp, you will have a higher resolution or higher contrast, not resolution, high contrast and high radiation dose. If you have a higher kVp X-ray, it will be low contrast and low radiation dose. So if I'm a patient, I will prefer to have low radiation dose. So I want a high kVp scan. If I'm a radiologist, I will love to have a high contrast scan. But we meet somewhere in the middle usually because that's the ALARA principle, as low as reasonably achievable, right? So we want to give maximum diagnostic output, but bare minimum radiation dose to the patient, right? But the basic science is when you decrease the KVP, the photoelectric effect increases. So photoelectric effect is inversely proportional to the energy cube. That's one numerical, and there is a second one. There's no third to it. So if you really want to learn something, if KVP is the energy of the beam, as you increase the energy, the penetration power or the KVP increases. You can see that the X-rays have penetrated right through the bones even here. And if you look at the left here, this is the perfect contrast. The contrast is difference between two different density structures. If you want to simplify it further, there is zero contrast between my two hands, but there is a contrast between my hand and the wall on the back. So contrast is defined as a difference between two different densities, right? So to differentiate two densities, I need a lower KVP. And that also answers many of your physics questions if you have, or any practical question, why mammography is done at say 20 to 40 kVp and the chest x-ray is done at 120 kVp. Why is that? Because in the breast you have to discern two closer densities which you can only discern using a low kVp, right? So this was one of the questions that was put in there in the as one of the three pre-test questions. So one was a higher KVP and one was a low KVP, right? So KVP determines penetration, milliamperes determine exposure. We'll come in a bit. Sometimes they are loosely used term, but we'll see how the effect of KVP and milliamperes happen in a bit. But for now, photoelectric effect is proportional to the atomic number. So if you have a high atomic number element like iodine, that will be very bright on the screen because it will have a higher stopping power thanks to its high atomic number, right? So more atomic number means more stopping power, more whiteness on your screen. Less atomic number is less whiteness, and similarly, converse is true for the energy which is driven by the KVP, kilo voltage peak, the strength of the X-ray beam. You can apply it to the periodic table. It looks scary, but I'm not asking you to cram it, but this will get your shade card corrected for any modality. Iodine and barium are our contrast agents. Iodine intravenous contrast, barium oral contrast. Why we chose them? Very high Z's. Contrast means you have to maximize the photoelectric effect. So maximizing the photoelectric effect on the atomic number is possible with iodine and barium, right? That answers question number one. So next time when you see a picture of a barium swallow or iodinated CT scan or anything using X-rays, these principles hold true. Now the question arises how the other colors work. So barium is very bright here because it's dense as well as it has a high atomic number advantage. The bones are next because the calcium has atomic number of 20. The soft tissues which are outside, you can see that on the CT scan, they are very, very you can say less white or very gray because they are single digit. Hydrocarbons form these things. So your shade card works on the principle of your periodic table. So next time when you see that, hey, I have to answer any question related to whiteness on the screen, or I want to stop more radiation exposure. For example, I work in a cath lab. What kind of a lead apron I want? I want a lead apron which should absorb or stop most of the radiation. So what will I get from here? The highest one, lead. That is why you wear an apron of lead and not a plastic apron, right? So lead absorbs thousands and more than the plastic. Plastic has a top effective atomic number of 8. That's why it's not wise to go in a cath lab with a plastic apron, but with a lead apron. So most of your questions are answered with this basic understanding. And I think that's all the physics you need to learn to know how X-rays work, whether it's a ankle radiograph or a skull radiograph or a chest radiograph, the physics never changes. And interestingly, that physics also is applicable to CT scan, which is a refined version of how we use the X-rays. All right. With that background of physics, where we know that what is white, what is black, what is gray, and how they are gray or white, we can move forward. Approach to chest radiograph. So again, there are two ways to look at anything, a tunnel vision or an open vision. And as advocated, chest radiography you should not look only for the lungs only, right? So you have to keep the vision open. There are so many structures outside the lungs as well. So you have to have an approach to deal with the entire chest radiograph every time you look at a radiograph. We call it a search pattern, right? So the search pattern is how you approach a scan. So you may have a template or the basic thing that you write your report on. We have a reporting software here. We have the standardized templates which are used by every resident, every attending, because we need to have a specific search pattern burnt into it, right? So this is basic anatomy. You can see aortic knob here. We'll come to the Silhouette sign in a bit, or the borders, what structures form these borders. But roughly, just at a glance, you can see there are multiple structures which are 3D and they are packed into a 2D environment. That's why there's a lot of overlapping happening. And hence, there's a lot of guesstimation of scope of wiggle room on a chest radiograph. So have a system, right? So don't start overwhelmingly looking at the entire picture, which is important as you open the scan. But then my basic approach is start from the center and explore towards the periphery. So you start with the central structures, which is mediastinum and the heart. We call it cardio-mediastinal silhouette because you cannot see heart separate from the mediastinum. That's why it is called a combined term, cardio-mediastinal silhouette, right? Then we have hilar structures, which are just emanating from here. Most of it is vascular structures or bronchovascular structures, although the lymphatics, which are invisible here, are also part of that hilum. So central portion, paracentral portion, then you go for the lungs. That's where we generally see pneumonias, pneumothorax, anything too white, too black is abnormal, right? So center, lungs, and then looking at below the diaphragm, which is very important. If it is upright radiograph, you may see air below the diaphragm, which is a sign of pneumoperitoneum, which may be iatrogenic, or it can be sign of a hollow viscous perforation as well. So again, it depends upon uh, how honestly you follow that search pattern. You can start from periphery and come in. That's totally up to you. But there has to be something that you should follow, right? So again, most of the time, as I said, will be spent on this portion, which is checkpoints. The interpretation is only this point number 5, right? We already talked about the systemness that you have to start with a system. Start from center, start from periphery, but make sure you look at each and every structure with the same attention, right? But this, we are usually more concentrated on the pathology part of it. But I will say the most important aspect is the technical quality of the film. If you know the technical quality of the film, you can compare two radiographs. You can always come clean when there are different rotations of radiographs in the ICU patients. That is super common, different technical factors. The exposure that somebody typed in there. So is one of them. So again, don't try to make a person sick. Sometimes the sick patient can also have a normal chest radiograph. So again, clinical sense, we'll see examples of many of them. I just wanted to make up a or a set a stage here that most of the aspect is on the technical quality of the film. That emphasis is very important. Let's start with the technical quality. So inclusion. Inclusion means all parts of X-ray have been included or not, right? So you cannot interpret a X-ray where there are no costophrenic angles, which is the angle between costa means rib, phrenic is diaphragm. So costophrenic angle, lateral costophrenic angle, right? So here the lateral costophrenic angle is missing, where you can see pleural effusions and other pathologies. The apices are chopped off. You can see that the pneumothorax in an upright patient usually shows up here. Abnormal air in the pleural space. Similarly, the soft tissue should also be included. So ideally, your chest radiograph should appear like this with a marker as well, right? This marker is very important, which is placed at the time of acquisition of the picture. So the first checkpoint is completeness of the picture. Second is projection, which is very, very important. Whether you do a PA or a AP projection, that changes a lot. This is the same patient. PA denotes the flow of the X-rays, posterior, anterior, which means the X-ray tube is behind you, and the film or the detector, based on whether you're doing digital or analog, is in front of you, right? So this is PA radiograph, and the opposite of it is AP. Technically speaking, PA is the superior radiograph, and every person deserves a PA radiograph because it gives the correct size of the heart. You can see spurious cardiomegaly here, and it removes the scapulae. You see these bones on the corner here are scapulae, or scapula on one side, scapula on the other side. They are out of field of view. That's a sign of a very good PA radiograph. Now the question arises, why will you do AP radiograph then, right? So let's first look at how we do PA radiograph. So this is PA radiograph classically. If you are looking at how to get a person scanned in a PA radiograph, you can see there is a detector here, X-ray tube behind the person, right? And the person has to do this kind of exercise, like this, shoulders and the elbows moved forward, which removes the scapulae from the field of view, and you have a better diagnostic capability, right? So this is how you do a PA radiograph. But the question still remains, why I don't do PA in everyone? Why I do AP if PA is so good? So this tells you a basic diagram of PA versus AP. So source on the front, which is X-rays, and detector on the behind is AP. You can see that since it is a cone beam, the heart size is magnified. And that's what you saw on the picture here. The heart size was magnified. But in PA, since the detector is snug with your chest, you can see there is no magnification happening here. So that explains one part of the story, that the right heart size is detected on PA, right? Now imagine a situation, a patient is in your ICU with 15 fractures. He or she cannot move, unfortunately. So how will you obtain a PA radiograph? The person cannot stand. You cannot shove the big X-ray tube below the person. So the only way you can do X-ray in this case is bring the X-rays on top of the patient or the X-ray tube and sneak the detector below the patient's couch or below the patient's bed sheet. So AP is something that is taken as a compromise in patients where you cannot get a patient to get a PA radiograph. We call it portable radiograph, which means the machine that you carry on the ICU has a limited horsepower. It cannot just churn in so much of exposure to get you the most beautiful picture. Hence, you are left with some of the limitations of this picture because the patient is lying, cannot take a deep breath in. That is why lungs are like accordion, they shrink, and you see spurious atelectasis and pleural effusion. So whenever you are dealing with the AP, give some grace marks to the heart size, cardiothoracic ratio, as well as to the basilar haziness. PA radiograph gives you the correct heart size and is better at looking at the basilar components of the lungs as well. Coming to after inclusion and projection orientation, left and right, generally it's considered a common sense, but definitely you always have to look at the marking in the top left, right? So if there is this metallic marking there, which is not digitally placed but manually placed on the person, the left will always be left on the monitor, whether I flip this picture or not. And that will tell me why this patient has a true dextrocardia, not the tech-induced dextrocardia, where you put a mark in the opposite side or digitally accidentally rotated the picture. So if in your practice you see so many dextrocardias, that is not because the nature is playing with you. It's maybe because you need to QC or educate your technological staff to put the markers on the right side. Cheating from a prior CT scan may be helpful as well. Because if you have a prior CT scan, this is a genital problem. It should not change from birth. As you can see in this patient, the history is very important. It already gives you the diagnosis uh, to some extent, but you can see dextrocardia here. The patient has this triad happening there. That happens in a very particular syndrome where your cilia does not function, Cartagena syndrome in short. So the cilia here are faulty, and you can see their tram track appearance here. If you look closely, that is sign of repeated infection leading to bronchiectasis. Bronchiectasis means uh, ectasia of the bronchi. Ectasia is dilatation, but it is permanent, irreversible dilatation. That's why it becomes a pathology. And everyone on the chat, it's great diagnostic skills you have gotten. So that's correct answer that you put in there as well. So Similarly, orientation is very important to talk about situs inversus and Cartagena syndrome. Rotation. Okay, rotation is a very important aspect of comparison radiography. If you're comparing two radiographs with each other, make sure they are optimally rotated out, which are not, then you have to account for the rotation because you cannot control the patient rotation. Sometimes patient can be tilted like this or this, depending on the discomfort the patient has. Our hospital policy says in the ICU, you should not move patients or the lines and tubes on top of the patient just to get a best picture because the things can be, there can be collateral damage of some kind. So we live with these rotated films, but there is a science behind it how to check for rotation. So in every radiograph, in the center is the thoracic spine, which is kind of overlapped on the mediastinum, sternum, and the heart. So that there are tiny droplets in the center, which are spinous processes. So those are our yardstick to find out if the patient is centered or not. You can see that here, there's a drawing here from the medial ends of the clavicle to the spinous processes, the distance should be the same. If the patient is rotated, that thing will open up, right? So the patient has more distance between the right clavicle medial end and the spinous process as on the left. What does that change? That changes the attenuation parameters, the thickness of the patient, the distance that the X-ray has to travel, and all those factors. Ultimately, if you really want to cheat, is if the person is rotated on the side the clavicle is nearer, lung is wider. If you look closely, this lung looks little bit wider than this lung, or this lung looks lucent. If it is not that pertaining, this is your test question, where somebody said, with no offense, eosinophilic pneumonia. When you say chronic eosinophilic pneumonia, there are two things against it in this one. Let's talk about it. Chronic means it will not vanish in 6 hours, right? And again, you start with a big heart, cardiomegaly. There's a device here which is supporting the heart. So you already know that there can be something that can happen. You can shout out pulmonary edema here, right? I think what my resident did in this case was a left-sided pulmonary edema. I said, how common is asymmetric pulmonary edema? What is the common explanation for this lung turned white and all of a sudden became normal few hours later is patient rotation. I drew these overlays for you just to say that the patient was centered here, patient rotated here, and centered again. So when you're comparing two radiographs which are dissimilar, they may be from the same patient, they may be from the same day. This is kind of artifactual haziness of the left hemithorax because the patient is rotated here and the side the clavicle is closer to the midline is always whiter. So make sure when you are comparing, this checkpoint is always on the top, right? Similarly, you can see the heart size changing in few hours as well and coming back to the same because the rotation also affects the obliquity of the heart. This is a 3D volume rendered scoop of the vasculature from a CT scan, a fancy diagram, but when you do the 2D maths to it, the heart will be of this size based on how rotated the patient is, right? So patient rotation has implication on the heart size as well as on the lucency or opacity of the heart, lung fields as well. Penetration and exposure, right? So both are together and literature is divided, but I will try to segment them in a way so that we can make sense out of it. This is very important, and this is where we as doctors do not so well. Not everyone, but again, penetration and exposure, we start talking in terms of electricity rather than patient care. And that's where we lose it. We say penetration kVp, kilo voltage peak. That is the voltage in the transformer of your machine that is used to boil the electrons or the photons which dance towards your body and then put the picture on the screen, right? So this is what we are talking about as the kilo voltage peak, the highest voltage that is being used to produce that X-ray. That has an implication on the strength of the X-rays, how penetrating those X-rays are. As the word says, penetration. So if you increase the voltage, it will increase the penetration, right? And there are yardsticks for judging the penetration based on the pictographic landmarks, like the vertebral bodies. If you see too many vertebral bodies, then you are maybe over-penetrated, which means you got more pressure or more kVp there. And if you don't see anything, this means X-rays were not able to penetrate the person because of the patient-related factors or the machine-related factors. So this is the question again. This was one of the pre-test question. What is difference between these two scans? You can see that kilo voltage, low kilo voltage, or an optimal, we can say that, gives you this radiograph. High kVp, the penetration is so high that the X-rays penetrated through the lungs as well as the rib cage same way. It does not differentiate between rib and the lungs. And that is the concept of contrast. High kVp leads to poor contrast. It may lead to better resolution, but that's a separate day discussion. But contrast is poor on the screen on the right. So more kVp does not lead to better contrast. It leads to poorer contrast. It may be intentional if you want to see some hidden areas, retrocardiac space or something. You are doing some kind of a fancy research study looking at lines and device or something hidden behind the heart. So that may be the reason. But again, an optimal radiograph requires a proper kVp. And the second thing is exposure, right? So again, kVp and MAS can be clubbed together as an exposure, but I keep milliamperes as the index for whiteness of the screen as well, right? So milliamperes is the amount of current that is flowing, right? We'll come to that. If you bear with me for another slide, I'll clarify your doubts as well. So when you see a whiteout picture, what do you think about it? It may be a penetration or a KVP problem or a MAS problem or a combination of both. Imagine you put a lead sheet in front of the machine and then do that exposure. What will the color of the X-ray? Pure white or pure black? It will be pure white, right? Because all the X-ray beam is dark. So similarly, if you expose blankly, it will be dark black or dark gray in color. So I have a very simplistic way where you will never think about KVP and MAS again. Imagine you are not taking a radiograph, you are watering your favorite plant in the garden. To plant, to have the optimal growth of this plant, what you require is optimal pressure, which means you will squeeze the end of the tube that much so the water stream reaches the plant. And number two, amount of water coming out of it is optimal so that there is some water to make that plant happy, right? So if you have either of them lower, then you will have less amount of water. If you have too much of pressure, all the water will overshoot. Now try to think about these three scenarios in terms of radiography. It's essentially the same. So you can, next time talking about kVp as pressure and milliamperes as amount of water will give you the same understanding. I don't want to muddy the water further, but all the laws of physics also follow the same dictum. If you love physics like me, pressure, voltage, and temperature work the same way, right? So try to not to turn a hot iron to understand the concept, but watering the plant is more safer. So that example is better. So whenever you're in a dilemma about KVP and MAS, remember this example. All right. The final frontier before you can actually give a disease or make a person normal is degree of inspiration. So all these technical qualities appear to be very tedious. But once you have read like 50 radiographs, this becomes your inner sense. You just open the X-ray, you already know what you see that. Maybe I will recommend you adding a line on the top of your template which says the quality factor, the patient is rotated. In all my reports, I always say the patient is rotated towards right, or it is an underexposed film, portable radiograph. It's a good habit to do that because that way you will never forget to check for these important things before rendering pulmonary edema, eosinophilic pneumonia, or any sinister pathology. Okay, go. So, degree of inspiration. So, degree of inspiration is the final frontier. So, it's very hard to assess the degree of inspiration, but we tell the patient to take the deepest breath and then we do the click, right? So how we'll know that the technologies which might be sitting few miles or few kilometers away and getting this picture, how will I know the patient took a deep breath or not? We generally count the ribs, right? Anterior and posterior ribs are counted differently, which is the peculiar aspect about human physiology. If you look at our rib cage, if I'm talking about the vertebrae where my thumbs are coinciding and the cartilages are beyond my fingertips. We are not arranged like this by Almighty God. We are arranged like this, which means you are bent forward. That means you see more posterior ribs than the anterior ribs, right? So whenever you take a deep breath, that's how your physiology works. Your lungs expand because that oblong thing becomes vertical, right? So when you're talking about the ribs, always start from the vertebral column. Start counting like 1, 2, 3. You can see that the third rib anterior aspect is here where my cursor is, but the posterior aspect is where 3 is written. So for your understanding, the posterior ribs are labeled on the left, and the anterior ribs are labeled on the left and the left of the patient, and the anterior ribs are posterior ribs are labeled on the right of the screen or the right of the patient. Again, it's always confusing right versus left. That brings down a common confusion. What is a right lung or a left lung, right? Imagine that you're facing a patient. If you can imagine that way, you will never get your left and right wrong because your left hand is always facing the right of your patient. So on the screen, this is right lung. All right. So that's why inspiration cause trouble as well. Less inspiration, as you can see, you can count the ribs here. 1, 2, 3, 4 anterior ribs. Count here 1, 2, 3, 4, 5, 6. So you already know you're comparing apples with watermelons here. So for an apple to apple comparison, you have to do that guesstimation. You may waffle in the end in your report saying, oh, haziness in the lower lobes is increased from the prior study, which may be due to lung hypoinflation versus atelectasis slash pleural fusion. But add that possibility to the comparison rather than some therapies change for that patient based on just this comparison, which is not a visual comparison at all. All right. So now there are too many ribs that are above the diaphragm, and the diaphragms are flat here, right? So that is the other aspect where the patient is air trapped. You cannot breathe out all the air. That is called chronic obstructive pulmonary disease in fancy terms, right? So whenever you see flattening of diaphragm more than 10 posterior ribs above the diaphragm, or more than 5 to 7 anterior ribs above diaphragm, this means there is so much of lung parenchyma expansion, hyperexpansion happening there, which happens in smokers and other chronic obstructive pulmonary airway diseases. All right, so we spent majority of the lecture trying to understand most of the things that we do. Normal anatomy, I think we will not have much time to cover pathology, but I think the message is conveyed. The quality control is more important. So PA radiographs, there are some visible structures as we talked about, like aortic knob, hyla, which should be biconvex in shape, right? Costophrenic angle, right? Cardiophrenic angle, right? So the names are like that. Apices, airways are always in the center. You have to assume them here. So, but there are some invisible structures as well. You don't see sternum usually unless the patient has a sternotomy wires. You don't see pleura. You assume pleura is always on the periphery. So any pleural pathology will show up here. Esophagus, aorta, and the spine. You can see the spine, but not to that extent. Before we go forward, we know that the PA radiograph we talked about, lateral radiograph is very important and kind of lateral radiograph is less known to people. So if I have to add something to your anatomy knowledge, it will be more on the lateral radiograph rather than PA. So first thing is by convention, since there are two ways to do a lateral radiograph. You can have your left side by the detector, or you can have your right side by the detector. Which one will you do? I think this is the convention. All the lateral radiographs should be left lateral, which means your left rib cage should be touching the detector, and the X-ray tube should always be on the right. So it should be right to left flow of X-rays. That's how a lateral should be doing, and nobody should be doing otherwise, right? So similarly, there's anatomy here. But the most important component is this is retrosternal window should be dark. And retrocardiac window should be dark. Not dark in this patient because this patient is chosen just to show a thick fissure. Generally, you should not see interlobar fissures as well. There must be some atelectasis or edema or some pathology going on, right? So lateral radiograph This area should be pitch black. This area should be pitch black. So retrosternal and retrocardiac. So again, so lateral radiograph is always done to confirm the findings on PA radiograph. You never get a lateral radiograph standalone. So it's always for confirmation. Let's go with an example, right? This is a PA radiograph. I'm not showing you the lateral for this one. It looks like anything is possible, but it's very peculiar. If I give this person a neoplasm, there is one thing against it. How can a lung mass be there, but no vessel or airway is distorted? It's kind of a hazy thing all over the left hemithorax. It's not pushing the heart here. Maybe, if anything, the trachea might be slightly towards left. So what's going on here? In those cases where you see that the entire hemithorax is hazy, somehow lateral can help you. This is a lateral radiograph. See, the fissure I showed you should be here. So now the fissure has moved anteriorly. And you can see this process goes from up to down. It's the entire left upper lobe which has gone shrunken, has shrunken into it. So, which means there's loss of volume and increased density, which are the two cardinal signs for atelectasis. So this is a left upper lobe collapse, which on a PA radiograph looks very sinister, but using the lateral radiograph, you were able to make that sense out, right? Similarly, the lateral radiograph, since it is a left lateral, you can even say that the right ribs and left ribs separate from each other. Since the rays started from right rib, they have to travel a lot of distance to hit the detector. That is why the right ribs are always more posterior and are more wider than the left ribs. Similarly, the right costophrenic angle is deeper and more posterior than the left costophrenic angle in an ideally placed non-rotated patient. So whenever you next time see lateral radiograph, try to discern these costophrenic angles not only by the gastric bubble, but by other clues as well, right? So sometimes even after doing that, you may still be in doubt. I can say like, okay, this is sharp and this is blunted, right? This is a magnified version. You don't know which angle is blunted here. You can also cheat from the CT. There is a Bok-Telek hernia here or a right posterior fat-containing diaphragmatic hernia, which is causing this kind of a blunting. So always compare with the prior examinations as well. In absence of any comparison, you may say few things based on how you judge it, right? Because the left costophrenic angle is perfectly sharp here. The right is hazy here. So the pathology is right. You may guess the pathology wrong, but you may guess the right side right in this case. Cardiothoracic ratio, our heart should be less than 50% of your hemithorax. In children, they have bigger hearts and smaller chest, you can say that. So that's why we have 60% as the cardiothoracic ratio cutoff. In the last few minutes, before I open it for kind of questions, we'll talk about normal contours of the mediastinum, which is very important before we can call it a day. Because everything in our mediastinum is superimposed on each other. It's very important to know what this outline means, right? Which is Silhouette. Silhouette is kind of a separation between two different density structures. As you know that the structures are arranged in the 3D environment in the normal human body like this. These are cardiovascular structures because we are studying the cardiomediastinal silhouette here. So definitely you have to remember this kind of contours of the cardiomediastinum, which kind of represent, if any of them is abnormal, that may be a pathology in itself. That's a separate day lecture. So paratracheal stripe can be thick. There can be lymphadenopathy or mass here. Azygous vein can be here or can be a normal variant, azygous fissure on a lobe. Similarly, SVC outline is here. When you place your central venous catheters, you always try to dissect these lines into three parts and then say upper SVC, mid SVC, or a superior cavo-atrial junction where SVC meets the atrium. Right heart border is purely by right atrium and the lower part by IVC. The left atrium only forms this part of the left heart border. The rest is left ventricle. That's why left ventricular enlargement shows like this. It's interesting to see there is no contribution of the right ventricle here, which is the most anterior chamber hidden behind here. So make sure you know these outlines with heart, because anything lateral to the aortic knuckle is abnormal until proven otherwise. right? Similarly, the same principles or similar principles are also applicable on the lateral as well, although not that religiously followed or not that robust. But PA ones are very, very robust, right? Dr. Khushbu, I think we should stop here. We have covered the anatomy as well as the approach to radiograph. What are
Great.
your thoughts?
Yes, yes. So it was indeed a very enlightening and talk which covered everything about the radiographs. I think all the radiologists and the younger generation who are here, because all of us have now kind of lost the art of reading radiographs as much, and especially with all the advancements in the AI, people are looking more and more towards AI to read the radiographs, which we realize sometimes is such a disaster if not if there's not a good quality check on that.
Yeah,
So
I
yeah,
can come with pathology plus AI lecture next time because I did not want to rush on these things. I saw the interest in the audience. So please, sorry to cut you. Please continue.
no, 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 absolutely. So that it does make sense because you're very right. Radiology, we and especially when we are talking about chest radiographs, we cannot cover it in 50 minutes. So it's indeed a difficult topic to take up. So I think we'll just go up with the questions and answers. Would you want to read them yourself, or I can just read them out and you can give answers across? So they're all in the Q&A. Your voice, I think you're on mute.
No, I see so many questions. So you can drive
Okay,
because
so I'll just drive through them. Huh. So, we have Pooja asking, does not low KVP mean low radiation dose?
it depends upon where the MAS are.
Great.
Radiation dose is a different determination. Many times we increase the KVP and reduce the MAS to reduce the radiation exposure. So radiation exposure is a combination of how both the factors move. If you increase both KVP and MAS, the radiation is going to increase. It's a mathematical product of both of them. So if you reduce KVP, definitely keeping the MAS constant, you will reduce the radiation exposure.
So why do we do left lateral radiographs and not right?
I have to check on that, to be frank with you, but that's a convention which is followed internationally and should be followed. Because for the sake of simplicity, we need to have one direction, right? It does not matter right or left, but that's how it goes worldwide.
How do we know if chest X-ray is an inspiration or expiration?
So we count the number of ribs as I alluded to. So if there are finite number of ribs, which is also kind of a guesstimation, but if you are starting your career with radiography, then kind of like you can count 10 posterior ribs above diaphragm, you can be pretty sure this patient has optimal inspiration. If the patient has COPD, the patient, there's no way to tell really what the state of inspiration, as the patient is in always state of what you call air trapping. That's why you have to look at other clues like diaphragm flattening and kind of hyperexpansion. But again, counting the ribs can come to your rescue when, especially when you are comparing two radiographs.
I think there are a lot of questions on lateral radiographs. So can you please explain the lateral radiograph acquisition and how to differentiate right and left diaphragm?
Yeah, so again, I can share the screen as well. But again, if you let me share the screen because it's very hard. Give me a second. I'm sharing the presenter view screen, but you should be able to get a sense from that. Can you see my screen again?
Yes, it's quite visible.
Yeah. So, so this is a lateral radiograph, right? And we talked about the X-rays are coming from, for example, my right towards my left. So it's going from right to left. So the X-rays will first hit my right ribs. Since it is a point source and it is kind of flaring out, right? It's an expanding thing. So the right ribs have more distance to travel. The X-rays that were stopped by the right rib is kind of like expanding in the as a cone beam. That's why those ribs are bigger. You can see the thickness of this rib is more than the thickness of the second set of the ribs, which are left ribs. Similarly, the costophrenic angle, the right costophrenic angle is first hit by the, okay, relax. Sorry about that. Okay, relax. Let me finish. Okay, let me finish. Sorry about that. So right cost, it's Sunday here, so I'm doing some part-time stuff here. So costophrenic angle, similarly, the right costophrenic angle is hit first by the X-rays. If you go by this picture, sorry, this picture. So this costophrenic angle, by the time it hits the detector, has gone in both directions. That's why it's a very important clue to see the deeper costophrenic angle or more posterior costophrenic angle as being the right probable. Does that answer?
Yeah, I think that does answer it well. So next we have, why is it that the left lung is darker than right in the rotated film and vice versa?
So it depends upon the rotation,
Yeah.
right? If
Yes.
you rotate towards the opposite side, so general clue is on the side where the midline is closer to the mid, or the spinous processes, which are yardstick for the midline, are closer to the clavicle, will appear white. And that's why the pre-test question was based on that concept to highlight that. I had a few other examples, but for the sake of time, so this is what we were talking about. Like, this is kind of the rotation that happened here. So had it been in the opposite direction, it could have been the other lung being whiter.
So cavoatrial junction is seen at what level on the chest X-ray?
Cavoatrial junction. I removed that slide, but again, there are different yardsticks for that. Maybe next time we can talk about it. But again, the short and sweet answer to that is where the bronchus intermedius meets the right heart border is technically the cavoatrial junction. Many people use, if the patient is not lordotic or something, intercostal spaces, so anterior intercostal space. If you are at the level of first anterior intercostal space, where I'm kind of like marking here, right, then you are in the upper SVC. Second is mid intercostal space. Third intercostal space is lower SVC. And here is the superior cavoatrial junction. So I wasn't sure I'm gonna cover lines and tubes. That's why I didn't bring it here.
Mm. So what are the typical KVP and MAS values for chest PA and portable X-ray?
So portable is variable, but I think if you understand physics better now, this answer is self-explanatory. There is already Almighty has made a lot of contrast between the ribs and my lungs. This is the densest object and this is the rarest object, which is mostly air. So I don't need a low kVp to discern them apart. That is why we do X-rays at 100, 120 kVp, right? And there was a question in the chat which says like, what is low energy beam is used for? Something like that. I think that is MAMS. When you do mammography, the breast tissues are soft tissues, and the cancer and the soft tissues are so close to each other. I have to give more radiation exposure to that person to discern them apart. Does that make sense on the KVP aspect?
It does. It makes it simpler and easier to understand. How can we say whether it's an AP or a PA view looking at the X-ray?
Yeah, so there are different ways to do that, but one of the ways, like if it is a properly done uh, AP AP view, a PA view, you should not see scapulae. You see that this AP has a scapula overlapping your lungs. Whenever you do this exercise of moving the elbows forward, this is done just to remove the scapulae from the field of view. That's one. But if somebody has done a poorly done PA radiograph, there's no way to tell that. So it's not a trick question. Somebody should mark on the top or on the bottom of the film it is PA or AP. But AP generally you will get sensibly. APs are generally of poor image quality than the PA, because portable machines don't have that wiggle room to generate that amount of exposure factors to go through the entire thickness of the patient.
Great. So I think with that, we are done with most of the questionnaires. We have excellent reviews from the webinar, and it was indeed a great webinar. Radiographs indeed are a lost art, and I think we need to get this reinforced more and more, because the information, the way you showed, made it so clear that the information that we get from it needs to be seen. So you need to have the eyes to see them. Thank you so much, Dr. Amit, once again, from the entire team and all the residents and other radiologists who've been around. And with that, we call it a day. And thank you everyone, for being around. And a very good night to all. Thank you, Dr. Amit, once again.